And then we'll start with some introductions. Dr. Rabi?
Okay.
Hi, my name is Kari Rabi. I am a family practice and addiction medicine team, and I've been working with our MOUD program since 2016.
Thank you. And Nikki, who happens to be our speaker today, would you mind introducing yourself?
Sure, I'm Nikki Giardina, and I am the infectious disease nurse at NACC, and I am on this ECHO team.
Thank you. And I'm Lindsay King-Cooney. I'm the harm reduction coordinator here at NACC. So we'll get started. I'm going to share my screen. We'll do some announcements, and then I'll hand it over to Nikki. All right, so welcome everybody. This is the Midwest Tribal Echo. We have the opioid use disorder education and treatment series. Today, Nikki is going to be talking to us about understanding and responding to opioid overdose. Just a little bit about NACC to get started. So we were established in 2003. We're an FQHC located in the heart of South Minneapolis in the urban indigenous community. This is a list of not only are we a primary care clinic, but we have lots of wraparound services. We have a daily dosing clinic, direct prescribe MAT program. We have social service support. We have a dental clinic. We have an inpatient intensive outpatient treatment center, and many harm reduction services. This is a list of current open positions at NACC. So feel free, there's our website down at the bottom. If you want to click on the job section, you can read more about the job descriptions. We have nurse outreach program manager, registration coordinator for medical. We have clinical care senior therapist, behavioral health therapist, pediatric provider, medical assistant, clinical manager, patient advocate for transportation, staff accounting, and grant accounting specialist. Some session guidelines, so please bring protected health information. If you could keep yourself muted if you're not talking. We'd love to see your faces, so if you could turn on your camera, if you're willing to do so, that would be great. If you can let me know your name, title, organization, and email in the chat, I can send out resources and can send you the post-evaluation survey to receive CE credits. Some announcements. Oops, I did not update this. Next session is August 7th, and that's going to be overamping stimulants, protective behaviors, and so-called psychosis with Ren Green, who's an LADC. This is just a list of other echoes that cover similar topics. So feel free to let me know if you want more information about that. And then, like I said, we do offer CME credit for those who are eligible. We just ask that you fill out the post-evaluation survey, which I'll put in the chat today, and then also email everybody as well. And then finally, case presentations. My email is down at the bottom there. So if you have a presentation to share, please feel free to let me know. They make for a great discussion. And I think that's it for me. I will hand it over to Nikki.
Okay, hi, I'm just gonna get my PowerPoint up. Oh, and slideshow. All right. Okay, thanks for coming, everyone. I feel sad for all of us because it probably means we're all home and not at the White Earth Harm Reduction Summit, but this will be a second best thing to be doing this week. So my name is Nikki Giardina. I'm a public health nurse. I work at Native American Community Clinic. I've worked here off and on since 2017 and have been working in harm reduction since like the early 2000s. And yeah, I've seen naloxone, and it's people's access to it go through a lot of different versions over the years. And so yeah, it's nice to have it be so accessible and available and legal and easy to give. And yeah, so I'm just going to talk about opioid overdose. Some of this is going to be just like a straight up naloxone administration training. So apologies if that's just very repetitive for you, but we'll talk about a little bit of sort of background and context, and then some harm reduction education around overdose risk and prevention, and then a little bit about the Good Samaritan law, or Steve's law, and how that would affect people who are responding to overdoses and administering naloxone. Yeah. And if anybody has any questions, feel free to interrupt me. Okay, so just to sort of start by defining what an overdose is, many different substances can cause overdoses. Essentially means that somebody took too much of a substance. How much is too much is going to differ from person to person and from substance to substance. A lot of that has to do with tolerance, and we'll talk more about tolerance in a minute. But essentially, particularly with opioids, although this is the case with a lot of substances, the more consistently you're taking opioids, the higher your tolerance is going to be, meaning both that the amount that you need to take to achieve desired effects is going to be higher, but also the amount that you can take without overdosing may also be higher. So that tolerance can be protective. People's vulnerability to overdose can have to do with other factors too, like their health status, whether they're taking multiple substances at the same time, and then just sort of contextual things seem to have an impact on overdose risk, like is somebody in distress, or in using drugs in what feels like a sort of rushed and pressured environment. Those things can contribute to overdose risk. So today we're mostly going to be talking about opioid overdose. So opioids can cause fatal overdoses. And what's happening there is that the person's breathing is slowed down or stopped. And so that is kind of at the point that somebody that's using opioids is no longer responding to that respiratory depression, that either slow or ineffective breathing or lack of breathing is going to be sort of the first step, in addition to administering the naloxone and calling 911. And then, yeah, so opioid overdoses can be reversed by administering a medication called naloxone, which is very safe to give and it's easy to give, and we're going to talk all about that today. So what are opioids? They're a class of drugs. Some are, illicit drugs like heroin. Some are prescribed like morphine. They all cause pain relief, and they can all cause respiratory depression. So the opioid in Suboxone, buprenorphine, is a little bit different and doesn't carry that same risk of overdose, certainly not to the same extent as others. So it's in a little bit of a class by itself. But other opioids, if one takes too much, can cause respiratory depression and can cause overdose. So with all opioids, if somebody uses them in an ongoing, regular way, they will have physical dependence, meaning they need to keep taking it to feel normal, and they need to take more and more in order to achieve the desired effects. If somebody has that physical dependence on opioids and then they suddenly either decrease or stop taking them, they'll go through withdrawal. And we'll talk a little bit more about that. Usually it's a set of symptoms making the person feel extremely unpleasant, kind of like a horrible flu with also a lot of anxiety and depression. And then that tolerance, so that amount of an opioid that somebody is able to survive taking because they've been taking opioids consistently, if that person either decreases or stops using, even for a relatively short amount of time, their tolerance will go down. So meaning that even if somebody is using a lot of fentanyl consistently, if they get arrested, say, and are incarcerated for, you know, a week, say, and they've gone through withdrawal, and then they are released, if they were to return to using that same amount of fentanyl, that could potentially lead to a fatal overdose because their tolerance is going to be way lower than it was prior when they were using consistently. So yeah, opioids include heroin, fentanyl, morphine, things like pills that you get prescribed for pain, often will be like a combination of an opioid and then a non-narcotic pain med like Tylenol. So like Vicodin's an example of that. And then methadone and Suboxone are also opioids, although yeah, again, Suboxone doesn't really carry that same overdose risk. And then other drugs are not opioids. So like meth, cocaine, alcohol, gabapentin, benzodiazepines, those are not opioids. And so naloxone doesn't have a direct effect on them. So if somebody's overdosing on a non-opioid medication, unfortunately, the naloxone is likely not going to do anything. But there really aren't downsides to giving the naloxone, even if it's kind of like a question mark as to whether the person took an opioid. So, you know, we kind of encourage when in doubt, give it, and worst case scenario, it just won't do anything. Additionally, even if somebody is only using cocaine or meth, let's say, it could be that there's also fentanyl mixed in with that, and they may not even be aware of it. And so there actually may be an opioid in their system unbeknownst to them, in which case the naloxone may help enough to, you know, lighten the burden of the different substances the person has taken and potentially bring them out of the overdose. Okay, so naloxone, the brand name is Narcan. So naloxone and Narcan are the same thing. It is an opioid antagonist. So it's like anti the opioid. It works against the opioid. Takes about 2 to 5 minutes to start working once it's administered. It wears off anywhere from like a half hour to 90 minutes. Again, only works on opioids, but if somebody took something that has a combination of things in it and one of them's an opioid, it could still be effective. Overall, very safe and easy to give. It's really basic kind of how naloxone works. So people have these binding sites that opioids will bind to, the receptors, and cause all of the different effects of the opioid, including pain relief, sedation, euphoria, and hypoventilation, so decrease in, you know, slower breathing or then eventually maybe no breathing at all. So that's what happens when someone takes an opioid. Now, naloxone fits into those same binding sites that the opioid does. And so when you've taken an opioid and those binding sites are full of the opioid, and then somebody administers naloxone, the naloxone essentially is able to like replace the opioid in that binding site, but it doesn't cause the same effect as the opioid. So it's like treating it as though the brain's receptors are all full, but of something that's not causing those adverse effects, like decrease breathing. And the receptors prefer naloxone to the opioid. So they would, if they have a choice of either the opioid or the naloxone, they'll opt for the naloxone. So the opioid is no longer bound to those receptors, and the person temporarily is not having the effects of the opioid. So it's kind of an awesome thing that this exists. The one thing to keep in mind is that it is just temporary. And so if somebody took a fatal dose of an opioid, is experiencing those effects, someone gives them naloxone, the naloxone kicks those opioids out of the receptors and fills them up. At the point that the naloxone wears off, that person may still have that fatal dose of opioids in their system. And so they can just go right back into that overdose potentially. So that's one of the reasons why it's important to have EMS on the way and try to not leave people alone, even if naloxone has successfully reversed an overdose. Okay, so we're going to talk about how to respond to an overdose kind of step by step. I'm going to try not to make it too complicated. We think it's really important for it to just be like very easy and kind of come automatically and naturally in that moment. So, the first thing you're doing, just really quick overview, the first thing you're doing is you're kind of checking, does this person seem like they could be overdosing? Are they responsive? Are they breathing? If not, call 911, and then you're going to administer naloxone and then start rescue breathing. So that sort of triple, so 911, naloxone, and rescue breathing, and you're going to kind of repeat those over and over again until something changes. I mean, you don't have to repeat calling 911 unless they haven't come in a while, but assuming they're on their way. So just about every 2 minutes, 3 minutes, you can reassess the situation. Is the person breathing on their own or awake yet? If not, keep giving naloxone and keep doing rescue breathing until something changes. So until the person is conscious, responsive, or until EMS gets there, or until you run out of naloxone, or until the situation becomes unsafe to stay in. It's important to really try not to leave the person alone, to stay with the person. And if there's more than one person responding, which hopefully in general there will be, particularly in like professional settings, multiple steps can be done at the same time. So we don't need to worry so much about the order in which we're responding, because different people can do different things. So the first thing we're going to do is just do kind of like a quick look over of the person. Do they look like they might be overdosing? So one of the key ways, sort of the key marker of might this person be overdosing and should I give naloxone, is if they're unresponsive. So if they're unresponsive, you could assume they might be overdosing. In addition to unresponsiveness, you might see some other signs like that, like slow, shallow, or lack of breathing, kind of a snoring, gurgling, or choking sound, changes in skin color, particularly in the nails or lips. So skin just looking kind of gray, pale, blue, purple, a limp body, and vomiting. And so then you can try to wake them up. If somebody seems like they might be overdosing and then you're able to wake them up, that's great. Then you don't have to, if they're responsive, you don't have to give naloxone. If they seem like they may still be in a medical crisis, you may still need to call 911. But yeah, and so inflicting just a little bit of pain can sometimes be a good way to wake someone up. So you can shout the person's name if you know it, shake their shoulder, give a sternum rub. So that's when you take your knuckles and rub them up and down the breastbone here. Sometimes like pinching the finger at the nail can cause enough pain to try to wake the person up. Okay, so if the person is either unresponsive or, responsive and seems like they may still need medical attention due to being, heavily sedated, then you call 911. And we always really want to encourage calling 911 in the case of an overdose. We'll go over specific reasons why, but sometimes the way that we're responding at the scene just isn't enough. So when you call 911, you could say, I have someone who's unconscious, not breathing. Really great, again, if you have multiple people there, you can stay with the person and start to administer the Narcan while you say another person's name, say, hey, Pat, go call 911. If you're alone and you have to leave the person, what the guidance is to do sort of like a little bit of the way that you would respond, then put them in the recovery position, and then go call 911 / get your Narcan and naloxone and bring it back. So like if you were going to do rescue breaths, do a few rescue breaths, then put the person in this position that we'll talk about it in a moment, then go leave, call 911, get your naloxone and maybe your AED if you're doing that too, and then come back. You're kind of wanting to give the person some amount of oxygen to, preserve their vital organs prior to leaving. This recovery position is designed to keep the person off of their back. So mostly so that if they vomit, then they don't then inhale that vomit, because that can lead to pneumonia and just, yeah, that's very dangerous. And so You just put them on their side and sort of weigh them down by bending the top leg over and then putting their hands under their heads. And this is called the recovery position. Okay, so why is calling 911 important? The naloxone may not work. It may be that the person's taken other non-opioid substances or maybe having a totally different type of medical crisis. If the person is overdosing and we give them naloxone and then that revives them, that can be pretty stressful. And so sometimes somebody has an underlying medical condition that then gets unmasked because of the intensity of that situation, and they do need immediate medical attention. If someone happens to be pregnant, and we'll talk a little bit more about the withdrawal aspect of being revived by naloxone, but if someone happens to be pregnant and they're given naloxone and they have an opioid dependence, so therefore when they receive the naloxone, suddenly they're put into sudden withdrawal. I mean, it's good, you know, you have potentially saved their life, but at the same time that those withdrawal symptoms can be stressful for the pregnancy and for the fetus. And so the person does need, you know, a higher level of medical attention at that point to care for the pregnancy, and that those withdrawal symptoms affect on the pregnancy. Theoretically, somebody could have an allergic reaction to naloxone. I don't think that's anything that we've ever heard of, but, you know, it's always good just to have EMS on the way. And again, like we talked about before, some opioids last longer than naloxone does, so the person may go back into the overdose after they've been revived. Another thing I want to mention really quickly, and we'll talk about this in some more detail, is that how you respond to these things also depends somewhat on context. And so this sort of like quick and simple opioid response, you know, essentially was designed for people who were using opioids with each other. So if I'm with my friend and we're both using opioids and all of a sudden my friend is unresponsive, I can be pretty sure that the reason they're unresponsive is from an opioid overdose because we both just took opioids together. But if so, then therefore my response being this sort of like targeted to opioid overdose makes a lot of sense. If you're out in the community or you're at work and you come upon someone who's unconscious, you don't really know, you may not know, you know, have they overdosed or is there something else going on? And so what we want to encourage is that in those situations where it could be a variety of causes for them being unresponsive or not breathing, we want to encourage you to sort of continue to use all the tools in your arsenal. So if you would have done CPR or you would have done, you know, gotten an AED, whatever, to use those as well as appropriate, and then incorporate the naloxone into that. And I'll show you what the American Heart Association recommends as the order, if you don't have multiple people to do different steps at once. In terms of the idea of, well, we'll talk about that in a minute. We'll revisit the idea of like rescue breathing versus chest compressions and when to do which. So that's coming. Okay, so in this situation, you've called 911 and then you're going to give naloxone. So naloxone can be administered either in an injection into the muscle or intranasally, so in a spray that goes into the nose. If it's given in a muscle, it's going to come in a little glass vial like this. Maybe I'm going to stop sharing really quickly just so that you guys can kind of see a little more clearly. So this is a vial of naloxone. All of the liquid in here is one dose, so you don't need to measure it as you're drawing it out. It'll come with this little colorful plastic cap, so you just want to pop off that cap. And then you see the top has a rubber part that you can stick a needle through. So that's where you're going to stick the needle through. When you get a kit that has naloxone in it, it should come with all the tools you need. So like inside this kit will be the naloxone and syringes. You're going to want to use syringes that are long enough to reach a muscle. So generally they'll be like an inch or maybe a little bit more than an inch long. Because if the naloxone is administered more shallowly, it may not reach the muscle, and then it just doesn't get absorbed as quickly, and we want it to act as fast as possible. So you have this syringe here. Sometimes when you wrap the syringe. This is annoying, but like the barrel and the needle, they twist together. So sometimes they're loose, and that can kind of be a hiccup when you're trying to draw the medication up. So we just don't pull it off like I did. I was just showing you, but just tighten it, you know, to make sure it's on there really securely. And then you can take the cap off. Essentially, then you just want to put the syringe into the vial and then pull all of the liquid out. A couple of things that can make that easier. One is to pull back some air into the syringe. So you can pull back like about 1 milliliter of air. And then you're going to put this into the vial and push the air into the vial. And that just helps you then, it helps create pressure that helps to draw out the liquid. And then you just draw all of the liquid out into the syringe. And this is kind of a tricky thing to show in person, to show not in person. But one thing to keep in mind is that you need to turn the whole apparatus upside down, because what happens is if you're trying to draw it out like this, the syringe, the needle itself isn't long enough and it won't be able to reach the liquid in the bottom of the vial. So you turn it upside down, so then all the liquid is right there. And then you need to pull the syringe back, to pull it down so that the tip of the syringe is submerged in the liquid. Because if you're trying, this is the thing that is the trickiest for folks, I think, when they're doing this for the first time. If you have the syringe in too far, the tip of the syringe is going to be in air. It's not going to be in liquid. So then when you're pulling the plunger back, you're just going to be getting air. So you need to have it almost like lower than you think it should be. Almost like, oh, am I about to pull it out? And then you pull down the barrel and you get all of the liquid. Now, then you just want to give it. I'm going to go back to sharing my screen. What you have here after you've drawn it out in the syringe, sorry, it's gonna be tiny again, but I think you could probably see what I'm saying. You'll have the naloxone here, but then you may have some air above it. And so if you go ahead and you give this, you're gonna be injecting some air into the muscle. You know, for like medical professionals, you know, it probably is best practice to push up all of the fluids so that you don't have any air in the syringe. If you forget to do this in real life, in a community setting, it's not the end of the world, because it's not going into a vein, it's going into the muscle. And so it's not going to be super dangerous to inject some air into the muscle. But if you think of it, you can push this up, and then you want to give it into a big muscle. And so we recommend either giving it into the deltoid, so that's just this on the side of the arm under the shoulder, and so like where you get a flu shot, or on the thigh, so essentially just like the top, maybe slightly outer meaty portion of the thigh. And when you give it, you want to go all the way in. So you're gonna, you know, if this is your muscle, this is somebody's shoulder, you're going to go straight in at a 90-degree angle. And sometimes you need to push a little harder than you think you're going to, and go all the way. So all the way to the hub. So as far in as the syringe will go. And then you're going to inject, and then you're going to pull the syringe out and do something with the syringe so nobody gets stuck with it. This says to use an alcohol wipe before you inject. I mean, if you're like responding in the community or something, please do not worry about that. Yeah, you know, I think it's becoming less common for people to be carrying around the injectable Narcan, and more common for people to have the nasal, just because the nasal is so much easier to give. And so this is what well, you can see it on here. You can see it on the tiny screen and on the PowerPoint. This is what the nasal looks like. Again, each of these little contraptions is just one dose, so you don't need, it can't be reused, but you don't need to worry about measuring anything. It is a much higher dose than what's in the vial. So in the vial, I think is 0.4 milligrams of naloxone, and then in this is 4 milligrams. So this is 10 times the amount of naloxone. The reason being is that when you administer this, more kind of just gets lost to the air because it's not being injected. The idea is that they're supposed to be the same amount effective. And so really, I think from like a medical standpoint, there's not one recommended over the other. We have heard sort of folks in the community saying that sometimes they think that the nasal doesn't work as well as the injectable, but I that's anyway, it'd be something interesting to gather a lot of information on. But yeah, certainly this is an effective way to administer naloxone. So you just peel the back off of the little contraption, and then you stick it into somebody's nose. So you're gonna stick the this long part, the nozzle, into their nose, about as far as it'll go, so that your fingers are up against their nostril, and then you're gonna press the red button or the pink button, and that'll administer it. And then remove it from the person's nose. It can't be reused, so once you use it, if you want to give more, you'll have to use another. Make sure not to press the plunger outside the person's nose. Like, you can't prime it like a inhaler or something like that. You'll just waste the dose. Sometimes people ask, what if someone's not breathing? How does this work then, to administer it through the nose? And so the answer to that is that they don't actually need to be breathing. They're not inhaling it. It's getting absorbed through the mucous membrane in the nose, like directly into the bloodstream then, kind of similar to the way that somebody who's snorting a drug is administering that drug. Okay, so then rescue breathing. Although a lot of CPR classes are teaching this, hands-only CPR, and this is not a CPR class, just to be clear, but hands-only CPR, really emphasizing chest compressions, not worrying so much about rescue breathing. The reason that with opioid overdoses it's a little bit different is because what's happening is that the person's not breathing, whereas often outside of the realm of, substance use, if you find someone who's unresponsive, it's much more likely that it's related to their heart. And so therefore doing chest compressions could be, really helpful to make up for the fact that the heart isn't beating, or the heart isn't beating effectively. But if somebody's overdosing from an opioid, particularly if they've just started overdosing, right, probably their heart still is beating normally, but they're not breathing. That's what's going on in this moment. So then giving those rescue breaths can be the most important piece, rather than doing chest compressions. Sometimes people will say that giving rescue breathing can, that can be the thing that brings someone back. And so just to be clear, what's happening with the rescue breathing is that you're essentially sort of buying the person more time. You're delivering more oxygen into their lungs, and then therefore into their bloodstream, so that vital organs like the brain are getting enough oxygen. And then that prolongs the amount of time that the person can continue to be in this overdose state prior to having damage to their brain or their heart. And so the rescue breathing, it's not in and of itself doing anything to reverse the opioid, but it's protecting the person while they're in a state of not breathing. Obviously doing rescue breathing can result in, like exposure of infectious disease from person to person. If somebody has the flu and then you're doing rescue breathing, it's possible you might get the flu. There also sometimes can be body fluids involved. There can be vomit, or there can be, sometimes there's a lot of there can be pressure on the gums in rescue breathing. And so then there can be some blood transmission. We do encourage people to use pocket masks. So in our naloxone kits, these are the pocket masks, and they just come in these cute little things you can put on your keychain. You pull it out, and then you unwrap it, and you put it over the person's nose and mouth, and it has sort of a one-way valve so that you can give breaths, but then things from their mouth are less likely to come back into your own. Some people may choose to not give rescue breaths in certain situations, or there might be like your organization that you work for may have a policy against giving rescue breathing, things like that. So, but it can be really effective in helping to save the person's life. You're just going to have the person on. So you're going to watch and see, are they breathing? If they're breathing normally and regularly, then you don't have to do rescue breathing. But if they're not breathing or they're breathing very slowly, you put them flat on their back. Just look at their face. Is there anything just, super visible over their face or in their mouth? Something you can easily just remove. If so, you can remove that. Then you're going to pinch their nose, tilt their forehead back, and lift their chin up a little bit. You're doing it kind of, so they call it like the sniffer's pose, like as though there's a flower above their face and you want their nose up as though it's trying to smell something. Pinch their nose closed, put your mouth over their mouth, and give 2 breaths, and then give 1 breath every give 1 breath about every 5 seconds. You want them to be normal breaths, not super intense breaths, because that can cause lung damage or can accidentally go into the stomach and cause them to vomit. You can see while you're doing it, is their chest rising? So then you know if it's effective or not. After doing that for about 30 seconds, check to see if they're breathing again. If they're not, you can continue to do rescue breathing. There's also some evidence that if somebody is in a situation where they are not going to do rescue breathing for whatever reason, that even in the case of an opioid overdose, when somebody's not breathing, chest compressions may be more effective than not doing anything. This is not, I'm not going to teach about chest compressions, but just something to keep in mind, that chest compressions may do something to help keep the brain oxygenated if somebody is not able to do rescue breathing for whatever reason. Okay, so then we've called 911. We've maybe given some rescue breathing. And after about 2 or 3 minutes, if the person is still unresponsive, give more naloxone. And essentially, you can keep giving naloxone about every 2 to 3 minutes, either until you run out or somebody wakes up or EMS arrives. It's not really possible to give like too much naloxone. It may result in, if the person is revived, that they're in more intense withdrawal. But if you've waited that 2 minutes and they're still not responsive, then you do want to keep giving it, because it can be that 1 or 2 doses just isn't enough. Particularly with fentanyl, it seems like people are requiring more naloxone to be revived. So if you're doing the injectable, we'd recommend doing second doses in a different site. And if you're giving the nasal spray, it can be a good idea to give the second dose in the other nostril, just to mix it up on the off chance there's some reason it's not absorbing well through a certain site. Okay, so if somebody wakes up from an overdose, if they are dependent on opioids, so like taking them regularly, needing to take them to feel normal, giving naloxone will likely put them into a state of temporary withdrawal, because it's like all of a sudden, remember, the naloxone is at those binding sites, so the person isn't getting the effect of the opioids. So that can mean that they wake up really distressed. They may kind of like jump up, potentially be really confused. There may be vomiting, diarrhea, agitated behavior. Usually the withdrawal symptoms in and of themselves are not fatal. They're just really unpleasant. But like we said, if somebody has an underlying health issue, it's a good idea to have 911 on the way. But we can kind of reassure the person, you are in withdrawal because we gave you naloxone, but the naloxone will wear off and then your withdrawal will go away. Try to keep them calm. Easier said than done. But if, through verbal communication, you're able to explain to the person that the withdrawal will wear off after, maybe 35, 40 minutes, it may help to orient the person to what's going on. Sometimes people want to use right away because they're in withdrawal, and that's the way to reverse withdrawal. The problem in this situation is that the naloxone is blocking opioids. So if they do use again, they're not going to get the effects of that. And it can be dangerous because if they already have a fatal dose of opioids in their system and then they use more when the naloxone wears off, it just like further increases the risk of them going back into an overdose. So, we're trying to encourage the person to stay and wait for the ambulance to arrive so they can at least be assessed and possibly, maybe they might need to be brought into the hospital. Okay, so this is from 2015, but I'm pretty sure it's still current. American Heart Association has this flow chart, and we'll send out the PowerPoint of if you're doing full CPR, where do you put the naloxone into that? And so essentially what they're saying to do, if you have multiple people, do it all at once, right? If you have multiple people, you go call 911, get in the AED, you start administering naloxone right now, I'm going to start doing CPR. But if there's only one person, then you want to begin CPR and do it for 2 minutes before leaving to go call 911 and get the naloxone and AED. So 2 minutes of CPR, then leave, go get the phone and the naloxone and the AED, come back, give the naloxone, and then just keep going through the steps. Okay, so just a little bit on naloxone itself. So unfortunately, keeping it in your car is not a great idea. I know it would be a really convenient place to keep it, but extreme temperatures are not great for naloxone. I think particularly heat. And we want to avoid direct sunlight. That's why these bags are brown, to protect the naloxone from sunlight. You can keep it in your purse or your backpack. You do want to try to avoid having it get frozen. And so if somebody is living outside, it can be good to keep it sort of closer to their body so that the body heat helps it stay liquid. If your naloxone froze and you're in a situation where you need naloxone and it's all you have, I mean, once it's thawed, you can still give it and it'll probably still be somewhat effective. If you're not in that situation though and your naloxone's frozen, then go to a place where you would get your naloxone from, like here, and just trade it in, and then you can get new naloxone. If your naloxone's expired, kind of the same thing. You can bring it to us and then we'll give you fresh naloxone. But if you're in a situation where you need to administer it and it's all you have, go ahead and give it. Studies are showing that naloxone seems to stay very effective for at least a couple of years after its expiration date. But, officially trade it in and get some new naloxone. Okay, so just some sort of harm reduction thoughts right now about overdose. Some risk factors that can increase someone's risk for overdose can include if they're using alone, obviously if nobody's there to respond to them if they overdose, that's really dangerous. Using multiple drugs at the same time, particularly like multiple drugs that are depressants. Someone who has had a history of overdose has a higher likelihood of overdosing in the future. Recent period of abstinence or decreased use, again, reduces that tolerance. Some kind of health condition that may just make the person more vulnerable. Dehydration, malnourishment, sleep deprivation, someone who's older, and then anything new. So if somebody is using substances that are coming from a new person, or they're using a new drug, or they're using it through a new route, those can lead the person, like it's the first time ever that they're injecting, for example, that can lead to a higher risk of overdose. So some strategies to reduce the overdose risk. So try to avoid using alone when possible. For somebody that doesn't have somebody in person who will use with them, there's a great service called Never Use Alone. I think it's just like neverusealone.com or .org. You can Google it, I'm sure. And essentially what that is you are on the phone with somebody and they get your address and then they, where you are, and then they stay on the phone with you while you use. And if you stop responding to them, then they will call an ambulance to your house. So, but if you don't stop responding, then nothing happens. They won't call. Doing a tester shot. So that's the idea of doing sort of like a smaller initial injection, injecting a smaller amount of a drug to see where someone's tolerance is at or what's up with the new supply, how strong it is. Using in a safe location where you can take your time, something that's well lit, where you're not afraid someone's going to come banging on the door. Just, when people are sort of desperate and rushing, things get riskier. General health maintenance, so sort of preventing dehydration, malnutrition, stuff like that. Initially, for a long time, we've had in this PowerPoint that, other modes of substance delivery. So like injecting carries the highest risk of overdose theoretically, and so then using in other ways like smoking and snorting have a lower risk. Well, recent studies have actually shown that despite the fact that there's been like a big movement from injecting to smoking, particularly with fentanyl, that overdose rates do not seem to have gone down. So it's not necessarily clear actually anymore that smoking specifically carries a lower overdose risk than injecting. Of course, it carries less infectious disease risk and things like that. But we don't know all of the pieces of the information, but that's become a little bit fuzzier. So,
Nikki, there is a question in the chat. I don't know if you want me to read it now or wait till.
Sure. Yeah, you can read it now.
Great. So as far as having naloxone on you while traveling via commercial air and you have it on you through security, would TSA have an issue with the IM naloxone kit? Oh, and then
that's a good question. Oh, sorry, go ahead.
Oh, Marissa said, I've traveled with naloxone, both IM and nasal, and have had no trouble. Since syringes are used for other medical needs, it isn't seen as a hazard. This is personal experience. And some,
yeah, I guess I would say I've had the same personal experience of never having any trouble traveling with naloxone, either like the IM with the syringes or the nasal. I think it probably somewhat depends on where you're traveling to. So like anywhere in Minnesota, it's legal to have naloxone and it's legal to have the syringes that go with naloxone. But it could be that if you're flying to a state where that's not legal, that could potentially be a risk. So I don't really know the answer to that question. However, that was good timing because we're about to talk about sort of the legal status of naloxone in Minnesota. And so a lot of this information has come from the Legal Rights Center. And I suspect that if you were to reach out to them, they may have resources about naloxone's legal status and the legal status of carrying syringes with you in other states. And of course, many other states have similar protective laws to this, but unfortunately not all of them. So and it may be that in some of those states carrying the nasal is a better idea than the injectable. So yeah, so the Good Samaritan law is kind of a general name for these types of laws. They do a few things, and they often, sort of like outside of the realm of overdose, they protect people from being, they give people sort of legal protection if they're responding to somebody who is in a medical crisis, if they're sort of responding in good faith. But specifically for overdose, and specifically for the law in Minnesota, which sometimes people will call Steve's Law after Steve Rumler, who was an individual who had a fatal overdose. And then, a lot of the response to his overdose then led to the passing of this law in Minnesota. So it makes it legal to carry naloxone in Minnesota and to carry the syringes that you would use for that naloxone if it's IM. It also provides some immunity from being charged or prosecuted for simple drug possession, both for the person who is overdosing and receiving that medical care and for the person who responded and called 911 and is, potentially administering naloxone. So again, it differs by state. We actually had a prior ECHO presentation about a year ago, maybe, from the Legal Rights Center, all about Steve's Law. And so I've linked it there. That's a link directly to the YouTube on that. And then that's, their website. So I really encourage people to go listen to that whole presentation because it was awesome. But a few more details on Steve's Law. So specifically that Good Sam Law in Minnesota. So there's immunity against charges for possessing small amounts of drugs or possessing paraphernalia. In that presentation, they talk about the actual which types of drugs are protected and the amounts. So, and they are pretty small amounts, the idea being that it's just possession and not like intent to distribute. The immunity is only for the person who's overdosing and the person who called 911 and has stayed with the person until first responders arrive. And so other people at the scene are not protected and can be charged for simple possession. So again, it's only for a limited amount of substances, and there's not immunity, as far as we understand, for like either outstanding warrants for anybody or for other criminal activities. So like if, you have called 911 and you're the person responding, but you also have, an unregistered gun on you, for example, you could still be charged for that. So, and then apparently information gathered from the overdose scene can then be used, by the police to prosecute other criminal activities later, unrelated to the, possession that the person has immunity against. So, it's helpful. I mean, the idea is that people sometimes either don't call 911 because they're afraid of getting arrested for having drugs on them, or they wait to call 911 and instead they try to like clean up the scene first, right? And so this is supposed to be protective against that you will not get in trouble because you have some drugs and some paraphernalia lying around. The police show up, they can see you've been using drugs, this person's been using drugs, but you won't be charged for that if it's just the person overdosing and the person who's responding. Apparently you can still be charged with buying and selling drugs. And so I think the Legal Rights Center in their presentation just sort of discourages people from like in talking to the police saying, oh yeah, he sold me this or something like that. So, oh, and that's it. Sorry, such an abrupt ending. But that's what I have. Oh, I did want to talk a little bit about, where you get naloxone. So you can get naloxone from us at NACC. So feel free to reach out. You can reach out through this email, through the ECHO itself. We really want to be able to provide people with just a lot of naloxone, whatever amount that they need. There's a lot of local organizations that also distribute naloxone. And so if you're interested in more information on that, please feel free to reach out. You can also get it over the counter now from pharmacies. And you can ask your doctor to prescribe it. So there's a variety of different ways to access it. But MDH and DHS, the city of Minneapolis, for example, provide lots of funding to community orgs to make naloxone very available. And so it should be pretty low barrier. And that is it. So if anyone has any other questions, I'll stop sharing. Mm-hmm.
Does the nasal Narcan have the same hot cold?
I think so. Yeah, I think it's the same. So the question was like similar to how we talked about temperature for the injectable, does the nasal also, should you also avoid like freezing or overheating the nasal? I said that I think so. I think that, you just want to prevent any source of naloxone from getting either too hot or too cold. Yeah. Thanks, Ty. About how long does it take for tolerance to return to previous levels after a break in use? Meaning for tolerance, meaning like how long does it take for for tolerance to drop, or meaning after you return?
Yeah, sorry. This
okay.
is Sarah. I didn't ask that question very clearly. I know that when, say, somebody has spent time away from their drug of choice, particularly opioids, their tolerance sort of returns to a lower level. But how long does it take for the previous level to reassert? So that I know it goes back, but
Like
how
once
long?
the
Is it a
person
week?
starts,
Once the person
using again. Yeah,
Yeah.
I don't know if I know like an exact. I'm looking at Dr. Robbie to see if she has an idea. It probably varies really.
I think it varies depending on the use and the substance. I mean, like for example, fentanyl would be different from heroin or other things, but I think that it can be within days.
Yeah.
But it's a trajectory depending on the use. And I'm sorry, I know generally the answer, but not specifically the answer.
No, that's really helpful though, if we're talking about, I mean, even, and I understand it's not really a very specific amount of time, but days is helpful as kind of a range. Like, we're not talking about long periods of time. So thank you. It's sort of a counseling point. So thanks.
Yeah, and I think another piece of education that can be given around that is that just because there's so many various aspects to influencing where someone's tolerance is at, that again, like kind of starting slow, doing that tester shot, seeing how you respond and not making somebody not making an assumption about their tolerance that could potentially put their life at risk can be helpful. And I think that, in the way that people use, I mean, the problem is that the drug supply is so unpredictable and unregulated, right? But like, I think the way that people use who are using regularly, often they're pretty familiar with, like, they can tell a lot about their tolerance level based on doing things like tester shots or, and so just sort of using that, that critical thinking to be like assessing oneself. And
That's great. Thank you. Just helping people pay attention to their own body and their own signals. And you're absolutely right. I mean, drugs are so different from different batches and so on. Thank you.
Mm-hmm.
A lot of praise in the chat for you, Nikki.
Thanks, Lindsay.
Does anybody have any other questions? All right, well, thank you again, Nikki, for presenting today. Thanks y'all for joining. Next session is August 7th, and the topic is going to be overamping with Ren Green. I hope you can join us again. Thank you. Have a good day.
Thanks, everyone.